No. We only have the mouth, but just be careful with the mouth because sometimes it's. Just 1 second.
That's fine.
Okay, so you only have to click on your name.
Yeah.
And my thing is there, like this. Okay.
And if I want to, let me just see if I want to
with
point.
that. But only like this.
Yeah.
Okay, I'm
I
sorry.
just leave it now. I
Yeah.
leave it.
Okay.
That's fine. Okay. Thanks.
You're welcome.
It'll be easier.
I don't know if maybe we need to change slides. Yes.
Yeah.
Do you want to change slides for the... Oh, okay. There is no title of this session. Ah. Really? But your slides? Where's the IT person? Yeah, that's fine.
Sorry?
Yeah, that's fine. Very good. Let's start, yeah? See, people are still coming. Hello, everyone. We will be starting this session. So if you would like to please take your seats and settle down, we will be starting now. Okay, thank you so much, everyone. Welcome to all participants and to all of our outstanding speakers. My name is Alexandra Conversano. I am a scientific project officer at Global Health EDCTP 3, joint undertaking in Brussels, and I am today's co-chair. Today, we're going to discuss about advances in drug development in TB and HIV. We're going to hear from 6 outstanding speakers with previous experience in EDCTP projects. And I am here joined by my fantastic colleague and co-chair, Jean-Marie, who will introduce himself.
Thank you, Alex. Many of you know me from a previous life in EDCTP 1 and 2. I am Jean-Marie. I'm a senior scientific officer at EDCTP 3 in Brussels. I was happy when I was asked to co-chair this session because I saw projects that I saw when they were born. Now they are grown-up projects. So I'll be here co-chairing, but also happily listening on what they've achieved and where they are heading. So today is one of those sessions which is special for EDCTP because EDCTP, when it started, it was HIV, TB, malaria. And as you all remember, back in the days, if you come to this forum, you were hearing about these 3 diseases. And this session is talk about 2. So there's a good history. If I just look in the papers and see CHAPAS 1, CHAPAS 4, when back in the days we were looking at CHAPAS 1, no one thought there would be a CHAPAS 4. But here we are, talk about CHAPAS 4. And there are a lot of things that have been achieved. I'm just mentioning that it's not because it's my favorite project. It's just because it's one of those many favorite projects of mine. since the years I started with the DSTP. And I think I'm one of those persons who can talk a lot. So I'm happy that I have Alex with me, and I'll hand over to Alex to introduce the first speaker.
Thank you so much, Jean-Marie. Before I introduce the first speaker, I just wanted to let you know that we will be taking about 2-3 questions after each speaker presentation. So please feel free to jot down your questions throughout the presentations and ask them speaker-specific questions to each speaker. We will also be having a more general Q&A session at the end, if there is time, where you can address any question to any speakers. And for those of you joining us online, please feel free to use the forum app that has been developed especially for this forum. We will be monitoring those questions throughout and asking them to speakers as well. And if we run out of time, then the speakers will be able to answer those questions on the forum app for you. So without further ado, I would like to introduce the first speaker, Dr. Carrion Upton. Dr. Upton, if you'd like to take your place at the podium, please. Dr. Upton is a medical doctor with expertise as an investigator in clinical trials at TASC, focused on infectious diseases such as TB and COVID-19. Dr. Upton is the principal investigator of a lot of clinical trials, and she is currently the scientific officer for TASC. And her presentation title today is Early Bactericidal Activities of Meropenem, Erapenem, Amoxicillin, Clavulanate, and Optimized Remoplacin in pulmonary tuberculosis. So, Dr. Upton, the floor is yours.
Great, thanks, Alex. As you mentioned, today I'm going to be speaking about the early bactericidal activity, or the EBA, of meropenem, erta, amoxicillin clavulanate, and optimized dose of rifampicin in pulmonary TB. The study was done as part of the Antibiotic Consortium. So a little bit of background. We have a dire need in TB for alternative treatments for drug-resistant TB, for treatment intolerance, and also extrapulmonary TB. And repurposing drugs offers a much quicker path to accessing alternative treatments. We've seen this with our fluoroquinolones, linezolid, and clofazimine, which now make up the group A and B drugs recommended by WHO for drug-resistant TB. So looking specifically at carbapenem antibiotics, these are a subclass of beta-lactams, and carbapenems target the bacterial cell wall synthesis of MTB. We know from prior studies that meropenem has demonstrated anti-TB activity when paired with amoxicillin clavulanic acid. So again, a little bit more background on carbapenems and beta-lactams. Amoxicillin, given as 3 grams plus clavulanic acid, was investigated some years ago by Prof. Donald and was found to have no activity. And then meropenem, 2 publications have come out showing that meropenem has activity in an EBA study. So just to give everyone a little context of what an EBA study looks like, we typically give a drug in monotherapy to newly diagnosed patients who have TB, pulmonary TB specifically. It's a very controlled environment. They're admitted to the ward for 2 weeks and assessed daily. And these are the results that we get from overnight sputum samples. So we know from these studies that meropenem given as 2 grams 3 times daily was very effective. And then the COMRAD study evaluated whether lowering the dose would achieve a similar activity and safety profile, which it didn't. 3 grams was active, but 6 grams was more active. So looking specifically at our study, this is a TASC-003 study, a 2A EBA. It was an open-label randomized trial, and we recruited HIV-negative adults with newly diagnosed smear-positive, rifampicin-susceptible pulmonary TB. The results of the first cohort have already been published, and we're compared to historical data, but here we present the full cohort. So our study design, all recruited participants underwent up to 9 days of screening. Obviously, we tried to limit that where possible, and then received 14 days of inpatient treatment. During these 14 days, they had overnight sputum samples collected. At the red dots show the time points at which those samples were collected for those 14 days, and they had treatment-emergent adverse events assessed daily. Once they had completed their 14 days, they were referred back to standard of care, which is Rifafor at the clinic, and we followed them up 2 weeks later. There were quite a number of regimens included, so It's going to take a second to go through this in the next slide, but 4 of them included meropenem, 2 ertapenem, and both of those were given with amoxicillin clavulanate together, and then 1 arm just investigating the amoxicillin clavulanate by itself. And then the last 2 arms were rifampicin high dose or optimized dose rifampicin of 35 milligrams per kilogram with the amoxicillin clavulanate, and then our control arm of rifafor. The target was 15 participants per arm. We didn't get 15 exactly per arm, and then 8 participants on the control arm. So again, 9 arms is a lot to go through, but these cohorts were recruited sequentially, so cohort 1 followed by 2 and 3. And then of the 4 meropenem arms, specific differences that I'd like to highlight is that in cohort 1, 2 and 3, we all had 6 grams total daily, but in cohort 1, this was infused once over 6 hours per day. In cohort 2, it was given as 3 grams twice daily, infused over 1 hour, and in the final cohort, or arm 7, this was split into 2 separate groups, which was meropenem 6 grams given over 1 hour, and then meropenem 4 grams. And then specifically in terms of ertapenem, all ertapenem patients received 1 gram daily. In cohort 1, this was intramuscularly, and in cohort 2, this was intravenously. And then lastly, in terms of the amoxicillin clavulanate, all arms received amoxicillin clavulanate, and this was given twice daily, except in arm 7, in which it was given once daily alongside the infusion. You're welcome to ask questions later about this. So our objectives, we had a few different objectives, but primarily to estimate the 14-day activity based on colony-forming units, which is sort of the standard metric for these types of studies, and this was determined using the rate of change in log 10 CFU. So this measures the bacterial load, essentially, of these patients and how that bacterial load drops over the 14 days of treatment. And then the second measure was also estimating the 14-day activity based on time to positivity in liquid culture, which I think is a little bit more familiar for the audience, and that was determined by the percentage rate of change in TTP. And then lastly, looking at the safety and tolerability. Now, key inclusion criteria, whether these were newly diagnosed pulmonary TB patients, they had to have a high bacterial load because that's what we're measuring, so they needed to be AFB smear positive, and they also had drug-sensitive TB as measured by GeneXpert. Key exclusion criteria were extrathoracic TB, diabetes, and HIV infection. Looking at how we analyzed these, our activity population was any participants who had evaluable measures, at least 1 at baseline and at least 1 on treatment CFU and TTP results. And then those CFU and TTP change over time was evaluated with nonlinear mixed effects modeling. Our safety population was any participant who received at least 1 dose of drug. So looking at our baseline participant disposition and baseline features, we recruited 132 participants, 20 withdrew during the study, and 112 of those were completed treatment. And our patients had, generally across all groups, fairly severe disease. They had about 2/3 had a 3+ AFB smear or a high positive readout on the cycle threshold for GeneXpert. And then cavitatory disease was present in 82% of the population. So looking at our results, and again, this is a lot of arms to look at, but essentially what you see on the right is our predicted individual CFU over time. So in each group, the line represents the median effect that we saw over time, and then the shaded area is the 95% prediction interval. So key things I'd like to highlight here is that ertapenem given intramuscularly and amoxicillin given alone with clavulanic acid showed no activity in CFU at the doses that we tested. All other arms showed a significant decline from baseline in bacterial load. Rifampicin 35 milligrams with amoxicillin clavulanate and HRZE had the highest decline in CFU. And then interestingly, meropenem total daily dose of 6 grams, so whether that was given over 6 hours, whether it was split into 3 grams twice daily or infused over 1 hour, had the highest activity of the meropenem arms, higher than the 4 grams. The TTP results were pretty similar. The only difference here is that the ertapenem intravenous arm also showed no activity in this analysis. And the interesting thing to consider here is whether PK had a role to play here, and whether ertapenem was underdosed, as we saw the IV PK achieved a higher Cmax and AUC than ERTA-IM. And then just to put this in one graph in a little bit more context so that everyone can understand, this is a forest plot of our median and prediction interval with CFU on the left and TTP on the right. And we can see our rifampicin-based regimens did the best overall in both metrics. Our meropenem regimens then performed quite well, but obviously not nearly as well as our rifampicin-based regimens. And we can see there again the effect of the 6 grams over the 4 grams. And then our ertapenem and amoxicillin regimens didn't do very well and showed no effect. In terms of safety, 44% of participants reported at least one AE. Meropenem 6 grams over 6 hours, and ertapenem IM had the highest incidence of adverse events across arms. 94% of all AEs were mild or moderate, and half were considered related to treatment. There were 3 SAEs that were reported, but these were considered unrelated to treatment. They were related to TB disease, specifically hemoptysis and pneumonia. And then the most common adverse events occurred in the gastrointestinal system, so this was diarrhea. And then there were some cases of raised transaminases. Injection site reactions from the infusions or the intramuscular injections were infrequent. And lastly, in conclusion, so ertapenem and amoxicillin plus clavulanate do not essentially have measurable or meaningful activity at the doses that we evaluated over 14 days. But very importantly, meropenem total daily dose does appear to be more important than how frequently you're dosing it, how long you're infusing it for. And this is, I think, really important for those who are using meropenem, is that you can tailor the way that you give these doses to the patient's needs, their availability, and your staff resources. And then lastly, as we, I think, know quite well, optimized dose rifampicin is very highly active and it has comparable activity to HRZE. So lastly, thank you to the study participants, to EDCTP, to my co-authors, and our collaborators in the consortium, and the many, many more people who don't feature on this slide. So thank you.
Thank you very much, Dr. Upton, for this very insightful presentation. So we will be taking 2-3 questions from the room. So if you have a question, please raise your hand, and we have some roving microphones. Okay, please.
Thank you, Bouke de Jong from Antwerp. Really exciting presentation. The TB penem, it's an all-oral. Do you know if there is any expected activity? It would be fantastic if carbapenems can be given that way. Given that higher is better, I expect the levels will be too low, but do you know if anybody's found it? And then the mechanism of resistance, I'm curious what the insights are.
Great questions, thank you. So in terms of oral carbapenems, that is something that has been of interest for many years. We have investigated ferropenem, which was not successful. Currently, sunfetranum is under investigation, and then we know that tebipenem, I think, in vitro has activity, and that has not yet been investigated in a clinical setting. For the mechanism of resistance, we can chat about that after. I'm definitely not the microbiologist in the room, but yeah, we can have a discussion about that after. Thank you.
Thank you very much. I saw a hand here to the left. Thank you.
All right, thank you very much, Karen. Hussein from Malawi. I just wanted to ask, first, I don't see the overall use case of carbapenems in early bactericidal activity for patients who are confirmed to have TB, considering that we already know that the standard RHZE does reduce the bacterial load enough to actually reduce transmission to almost nothing by day 14 already. So what motivated this study to begin with? And just to add to that, maybe one use case that comes to mind is in the event that, and I think this is a standard, which is that diagnosing TB can take a while, especially in our settings. So with that in mind, would you then recommend that people use a sort of empirical regimen that includes carbapenems for standard patients, HIV patients who have some sepsis, or how do you also reconcile considering that carbapenems in our settings are used as maybe second line because of high resistance as well? Thanks.
Thanks, Hussein. Lots of questions there. The use case for a carbapenem. So I think the goal here was really to prove that the drug class works, and we've done that. We've done that now across 3 studies. So that we know beta-lactams and carbapenems are an option. Now the challenge is to find whether we can make them more accessible and more feasible to use, because an IV or an intramuscular drug is obviously going to be limited to a very select group of participants or patients. Treatment intolerance, drug-resistant TB, or XDR TB. One might even consider extrapulmonary TB like TB meningitis, where we know that meropenem penetrates very well and some of our first-line drugs don't. This is certainly not the drug to be using as your first line to treat patients when we do have HRZD and a number of more exciting regimens coming in the future. Your second question was on whether we should use meropenem as like a holding before we have a diagnosis of TB. Interesting thought, especially in a septic patient. I think that if you do think there's TB, you should probably start HRZD and then stop. It would be a lower risk than giving them something like meropenem, which does have activity, but nothing compared to HRZD. And then there's also, you need to be careful about monotherapy in these patients. But I think that there are ICU specialists probably also in the room who would be able to give much better advice on that.
Okay, yes, please.
Thanks, Karin. So I'm Beno from Tanzania. Just have one question. The number of participants who was early withdrawal, I feel that they are somehow very significant to me. Almost 20 participants is almost 15% of the total sample size. So I just want to know what are the reasons of this early withdrawal and if this has any impact in the final analysis.
That's a great question. And we do ask our participants across all of our studies for a reason. In this case, not many of them provided a very clear reason for why they withdrew. We do tend to find that if a drug is poorly tolerated, that's sort of what the participants tend to present with is, oh, I have family responsibilities at home, or I just don't really want to be here anymore, and things like that. They don't necessarily always say, the drug's awful, I don't want to have it. But I think that was something that we did see a lot of in this case, and a lot more than we would expect in an EBA study, is that there were a lot of early withdrawals in the study.
Okay, we have time for one more. Is there anybody from this side of the room that had questions and I had ignored their hands? Okay, please.
I'm Christian from Swiss Tropical Public Health Institute. When you submitted to the ethics committee, what was this is not a question to blame someone, but I'm just curious to know how was it justified to do this? Because we know that the standard regimen works well.
We know that, sorry?
That the standard regimen HRZE works well.
The standard regimen does work well, but there's a lot of scenarios in which it's not relevant. Drug-resistant TB, extrapulmonary TB, and again, in terms of developing the class for treatment of TB was really a strong rationale here. So it did go through ethics approval, and participant care is always given as part of these studies. That's first and foremost for our clinicians in the site working on these studies. I think meropenem has a lot of potential, and the class has a lot of potential for extrapulmonary TB and those hard-to-treat cases.
And I see this, but it's like kind of altruistic to join that trial.
Our patients do give a lot of themselves to us, which is very helpful for the field.
Thank you for that. And one more, if you'd like. I did see a hand here. At the back, yes.
Yes, Veronique Penla from Cameroon. Why did you select to combine artepenem to amoxicillin instead of using first-line drugs? And also you decided to exclude the co-infected patients with HIV. And we all know that among the patients in general, we have, especially in our setting, more than 40% of them were co-infected with HIV. So I don't know exactly what motivates you to exclude this population? Thank you.
Great questions, thanks. The carbapenem class is susceptible to an enzyme, beta-lactamase, and giving it with clavulanic acid blocks that so that it allows the drug class to work. So that is why meropenem and ertapenem were given with the beta-lactamase. Amoxicillin wasn't expected to have any activity, but it's the only way that we can access clavulanic acid, so it's required to be given together as a combination, as augmentin. In terms of excluding HIV-positive participants, EBA studies are a very controlled environment where we try to reduce the variability between patients as much as possible, because these are very small sample sizes of only 15 per arm for 2 weeks. HIV-positive individuals have a slightly different presentation, and one of those effects is that they have a very low bacterial load typically. So even if we do include them, they typically only make up less than a quarter of the participants that we include. But in this case, we selected to reduce the variability of the study population and only include HIV-negative participants.
Thanks, Karen. Thanks for the audience for the questions. I think we'll have, if we go well, we'll have a few minutes later for a general Q&A. And for now, I think I'll invite the second speaker. Our second speaker is Dr. Abbas Rugema, who's going to talk about optimizing second-line anchor drugs options for children with HIV in Africa, specifically 96-week results of the CHAPAS 4 randomized trial. Abbas, we often put studies into context, but I also wanted to put the name in context. I know the name Abbas Rugema as one of the early trainees on the early CHAPAS studies, so it's good to see that people have stayed on these kind of studies and following on what they've been researching many years ago. Abbas, over to you.
Thank you. Thank you for inviting me to make this presentation on behalf of the CHAPAS trial team. The focus of this presentation will be on optimizing second-line anchor drug options for children in 96-week results for CHAPAS 4 randomized trial. The background of the CHAPAS trial was that there are limited options and formulations for second-line antiretroviral therapy for children living with HIV, and that lopinavir is currently the only formulated boosted PI for children, though we know that it has challenges with formulation and twice daily administration. Darunavir has a high genetic barrier to resistance even after failing boosted protease inhibitors, but it has a high cost, and this is prohibitive, and it's not available as a fixed dose combination. Atazanavir is not co-formulated for children, though it has an advantage of once daily administration. The dolutegravir, which is in a different class, an integrase inhibitor, has a high genetic barrier to resistance, low toxicity, and once daily dosing. Now, the hypothesis and methods. The primary endpoint here was viral load less than 400 copies per mil at week 96. And the hypotheses were that dolutegravir would be superior to lopinavir and atazanavir arms combined. Darunavir would be superior to lopinavir and atazanavir arms combined. Atazanavir would be non-inferior to lopinavir, and TAF would be non-inferior to abacavir or zidovudine standard of care. The primary analysis was by intention to treat, and secondary by per protocol for non-inferiority comparisons listed above. The focus of this presentation will be mainly for the first three hypotheses, and the superiority threshold was set at less than 0.03 to allow for multiple comparisons. CHAPAS design was by factorial 4x2 open label, and the anchor drug randomizations were dolutegravir, which was given once a day, darunavir once a day, atazanavir once a day, and lopinavir twice a day. The NRTI backbone randomizations were TAF, which was given once a day. Abacavir ozidovudine, given with lamivudine as standard of care, and all doses were according to WHO weight ban. This study was conducted in 3 African countries, as you can see, the African map, in Uganda, Zambia, and Zimbabwe, across 6 sites. These sites had an embedded new sites, those who attended the symposium yesterday, to allow for capacity building of sites. And it was managed by the University of Zimbabwe Clinical Research Center and coordinated by the Medical Research Council, University College London. Overall, we randomized 919 patients, and these were spread evenly between male and female. Average age was 10 years, and essentially there were stage 1 or 2 category, underweight, and as you can see, there was an even distribution between abacavir and zidovudine for first-line therapy, and they had been on their first-line regimen for an average of 5 years. Now, looking at this, this slide is really very exciting, because remember that CHAPAS met COVID, or COVID met CHAPAS. And this shows you the capacity of the team to conduct this and do it very well. We randomized randomized the patients, and 99% of the patients started their randomized anchored drugs. 100% started their randomized NRTI backbones. And over 96 weeks, 99% of the visits were completed, even with the lockdowns and all the confusion that came with COVID. And we only had 1% loss to follow up. There was 98% time on allocated regimens, and 5 patients were started on their 3rd-line treatment because we continue to monitor for patient well-being. And we had 8 protocol planned modifications for TB and 1 error that was corrected at week 2. Looking at results, viral load less than 400 copies, which was the primary endpoint. Viral suppression was high in all anchored drugs, in all anchored drug arms. You can see they were all above 80%. And looking at the viral load primary endpoint again, in comparing the different arms, dolutegravir was superior to lopinavir and atazanavir by a 10 percentage point. Darunavir showed a trend to superiority to lopinavir and atazanavir, and atazanavir was non-inferior to lopinavir. Looking at the anchored drug effects, anchored drug effects were similar for different viral cutoff points, less than 60 and less than 1,000 copies at 96 weeks, under the different time points of week 48 and week 144, and per protocol populations. And this included the subgroups for first-line NRTIs, for abacavir against dovudine, and there wasn't any interactions, and including the predefined subgroups of viral load, sex, weight, first-line NRTIs, and CD4. When we looked at the CD4 count, there wasn't any difference. CD4 count increased across all arms, and there was no evidence of difference for anchored drug randomizations. Looking at the adverse events, dolutegravir has had fewer grade 3 or 4 adverse events compared to lopinavir, and there were more grade 3 or 4 adverse events, mostly hyperbilirubinemia, which was expected, that occurred in atazanavir when compared to lopinavir, and there was no evidence of difference for ART modifying events or severe adverse events. Important to note was the 1 death that we registered, which was non-drug, which wasn't drug-related. Child had advanced HIV disease. Looking at lipids, because of their contribution to cardiovascular events, especially the total cholesterol and low-density lipoprotein cholesterol, it was significant, as you can see. It was significant in lopinavir when compared to other arms. Looking at growth, change in weight, and BMI for age, Z scores, you can see the trend, the gray graph. You remember that the children started drug when they were underweight, and there was growth registered across other arms apart from lopinavir. We had a comparison for the different art combinations, knowing that there is information coming in for adults, that is TAF, dolutegravir in adults, and we didn't see any evidence of excess weight gain among children receiving dolutegravir and TAF. And this is very important because I remember Professor Dai telling me that never treat children like small adults. So this information, you see the graph in the bottom left corner, no different, like no weight gain for those who received TAF and dolutegravir. So in conclusion, dolutegravir-based regimens were superior to standard second-line protease inhibitor-based regimens with a favorable safety profile. Atazanavir-based regimens were non-inferior to lopinavir-based regimens. Darunavir-based regimens were non-inferior and showed a trend towards being superior to other PI-based regimens, especially atazanavir and lopinavir. Children on lopinavir had the poorest weight gain and least favorable lipid profiles. TAF-based regimens were superior to standard of care, that is abacavir or zidovudine. And for those who attended yesterday's symposium, CHAPA's symposium, we realized that child-friendly fixed-dose combinations of TAF given with dolutegravir or darunavir or tazanavir would increase access to safe and effective second-line ART options for children. We thank all the participants and treatment supporters, staff from all centers participating in the CHAPAS 4 trial, and the funders, especially the EDCTP, for making this a success. That is the CHAPAS trial team at a results meeting in Zambia sometime this year. Thank you so much.
Thank you, Abbas. Thanks a lot, Abbas. I think now we can maybe take 2 or 3 questions. Hands up. Yeah.
Hello, I'm Dagondwa from Malawi. I just wanted to get an idea of whether you looked at the influence of adherence and also HIV drug resistance on your outcome, and whether in your analysis or at baseline you collected some of this information. Thank you.
That's an interesting question. Like I said, we had a very robust monitoring mechanism for these patients who are on trial. And all that information was captured. And that's why, as you saw in the presentation somewhere, there are some patients that we actually changed. We were doing resistance tests, and there are some patients, I think 5 patients, that were started on third-line treatment. So we really monitored this. I think I don't think it would have been done like any better than the way we did it, because it was rigorous. Yeah.
Okay, thank you. Any other question? Maybe while we wait for another hand, I had a question for Abbas. You mentioned the 1% lost follow-up, but it looks like you are one of the exceptions, because we've been doing amendment to extend grants because they were experiencing actually almost total loss to follow-up. So in your case, the 1% follow-up, was there any specific measures you took across those 3 countries to keep that 1%?
Yes, I think when we look at the sites, there were 6 spread across 3 countries, but the setup of the trial was that we had frequent discussions and frequent meetings, sharing information on what is being done well, where, and we had a strong community arm in all these centers that were monitoring and following up patients, if anything or when anything happened, and I think that really helped. So that's how we standardized practice across sites.
No, good. No, thanks. Any other question? Diana? A question or comment? I see a lot of members of the CHAPAS teams. If there is an additional comment to make,
yeah,
so good.
We can all make comments.
I
can't keep my mouth shut, so sorry
No
for that.
problem.
No, it was just to add to what Abba said. I mean, we're doing retrospective resistance testing at baseline and in the failures, but that hasn't happened yet. We've only just finished the trial, really. So those added analyses will happen, just to add to what Abba said about obviously there was a little bit of resistance testing that might have happened if children went to 3rd line, but we're going to do that. And then the other comment about COVID was just to clarify that we counted, visits that were done by phone, because obviously we had a protocol to change things when COVID happened. And particularly, then obviously it affected recruitment, and recruitment was, actually it took 8 months longer, I think, altogether for the whole trial. I'm not quite sure how we managed financially, but we did. We had some co-funding partners as well. But so those visits where we've put that they were 100%, it was because some of those visits became either at home, as Abbas have said, or else by telephone.
Thank you. Good addition. Thanks a lot. I see hands in that corner.
Good morning. Thank you very much for an excellent presentation and for a really groundbreaking study. I'm David Moore from South Africa. I was just wanting to try and get a sense from you as to what proportion of the children that you were following up were initiated onto anti-TB treatment during the course of the trial, and how regimens may have been adjusted to accommodate the drug-drug interactions between rifampicin and some of the trial drugs? Yeah,
we started around eight patients on anti-TBs. And those who are on dolutegravir, we doubled that dose to accommodate for the rifampicin effect. Yeah.
Thank you for the question and answer. I think we will follow up again after the presentation in the general Q&A. Now I'll hand over again to Alex for the third speaker.
Yes, thank you so much. Okay, so. So the third speaker is actually a nice segue, and Dr. Chishala Chabala. He presented yesterday about the CHAPAS 4 study trial 2, but today he is here to talk to us about plasma concentrations of first-line anti-tuberculosis drugs in infants with HIV and severe pneumonia, a pharmacokinetic sub-study of the empirical trial. And Dr. Chishala Chabala is a lecturer at the University of Zambia School of Medicine, a consultant pediatrician at the University Teaching Hospitals in Lusaka, Zambia, and a part-time faculty member of the London School of Hygiene and Tropical Medicine. He is an investigator on multinational collaborative pediatric clinical trials on tuberculosis diagnostics and treatment, pediatric HIV treatment, and pneumonia. He's also a member of the Child and Adolescent TB Working Group and has previously participated on Pediatric National TB Program reviews in Africa and contributed to the guidelines developed group of the WHO. So Dr. Chabala, the floor is yours.
Thanks for the introduction. Yeah, so I was going to talk about plasma concentration of TB drugs in children who were recruited in the empirical trial. And I'm presenting on behalf of the empirical trial team. So the background to this study is that tuberculosis is associated with high mortality in infants and young children who are living with HIV. And giving optimal anti-tuberculosis treatment and antiretroviral therapy is essential in ensuring that we have good clinical outcomes, particularly in children who are severely unwell with advanced HIV disease. But we know that young children who are growing because of the growth, development changes that occur, the way they handle drugs is quite different from older children and adults. And therefore, it's important that we understand these pharmacokinetic parameters. So some of the pharmacokinetic work that have been done in children who are on anti-TB treatment suggests that those children who have a low weight of below 8 kilo, when dosed according to the WHO weight-based dosing recommendations, they are at risk of having low plasma concentration. But we have limited data on those children who have of low weight and have advanced HIV disease, as the case in the children that were in this trial. So just to give you an idea about what empirical trial was. So empirical trial is a randomized controlled trial that evaluated empirical treatment with CMV treatment and anti-tuberculosis treatment for children who were living with HIV who presented with severe pneumonia and were hospitalized. And these children were randomized to one of these 4 arms that are shown, and they all received the standard of care, which was intravenous antibiotics with presumed PCP, and they received cotrimoxazole, high dose, and steroids. Then they were randomized either to receive TB treatment with valganciclovir to cover for CMV, or with TB treatment and standard of care, or with just valganciclovir alone, or just standard of care alone. And when they were stabilized, they were all then initiated on antiretroviral therapy. This trial is being conducted in 6 African countries, is winding up recruitment in January next year. It's being conducted in Zambia, Zimbabwe, Malawi, Mozambique, and Uganda and Ivory Coast, and it's coordinated in Spain and Italy by 12 October Hospital and the Penta Network, and then we have partners in the Netherlands, France, and the United Kingdom. So focusing on the pharmacokinetics sub-study that was embedded, so we focused on the children who were randomized to receive TB treatment, or children who received treatment post-randomization, even if they were not initially randomized to the TB treatment arm. And so the aim was to evaluate the plasma concentration of first-line drugs in these infants who received TB treatment, and we targeted to recruit 50 infants. And they were dosed according to these weight bands that are shown, and they were receiving the WHO pre-qualified fixed-dose combination drugs. And this is how the pharmacokinetic sampling was designed. So children, when they were randomized, they received all the treatment that they were meant to receive. And at day 30 and day 90 and day 180, they had a plasma sample collected 2 hours after they had been observed to have ingested the TB drugs. And the primary endpoint was a 2-hour plasma concentration, which we compared with published adult reference for CMAX. So CMAX is when a drug is taken, there's a maximum concentration that is achieved, which is we refer to as Tmax, and usually this coincides with about 2 hours on average for TB drugs, and so that was our primary endpoint. And the laboratory analysis was conducted in the Netherlands by the University of Nijmegen. And for primary analysis of the PK parameters, we compared the geometric mean ratio for each of the component drugs. And then we also determined the percentage of infants who were within adult reference values. So these were the results of the children that were enrolled. And this summary is for the children who were at least had a sample taken at day 13, so 51 were enrolled and 2 were excluded because in one infant the sample wasn't collected, in another it was collected 4 hours post-dose. They were young, average 6 months, and just nearly half were male. In terms of their nutritional status, they had a low weight for age and low weight for height. And in terms of how they were spread out across in the dosing bands, the majority of them were within the weight band 4 to 7.9 kilometers. Sorry, kilos, not kilometers. And in terms of their antiretroviral drugs, so you notice that the majority of them were receiving triple nucleosides to allow for TB treatment. So 17 of them received abacavir combined with lamivudine and zidovudine. And then we had 13 who received lopinavir, and this was done in accordance with what the national guidelines recommended in the treatment centers. So some of them was boosted, if that was being practiced at the center, or semi-boosted or double-dosed. And the dolutegravir, when we started the trial, wasn't available, but it became available midway through the trial. So some children received dolutegravir. And then we have some children who were not well enough to be initiated on ART by the time that we were doing the PK sampling. And in terms of the TB drugs dosing, most of them received the recommended dosing ranges for the component drugs. So these were the results. I'll start with isoniazid at day 30. So the vertical axis shows the drug concentration, and then we have this green band which shows the adult reference range that we're using, and the red band is what the geometric mean of what we observed in the study, and the blue band we compared with children who were enrolled in the SHINE trial within the 4 to 7 to 8 kilo weight band. And each dot on the graphic represents a sample that was collected from each child, so there are 49 dots. And we expect that if these children were having drug concentrations similar to adults, they were all supposed to fall in that green band. But you notice that there was a lot of variability. And when we compared to children in the SHINE trial, although the children in this trial were in the lower achieved drug concentration near the lower margin, but they were not comparable to the SHINE trial, for example. And then when we looked at day 30 result, they were consistent at day 30, similar observations on day 90, and day 180 for isoniazid. And again, when we come to rifampicin, again, we notice that there's lots of variability again in the spread of the concentrations, and we'll find that on average, most of the children had low plasma concentration, similar to what was observed in children in this weight band in the SHINE trial. And we also showed this pattern remained consistent at day 90 and day 180. And then when we come to pyrazinamide, at least for pyrazinamide, most of them were having concentration within the reference weight band. We don't have a day 90 because pyrazinamide is stopped after the intensive phase, so we don't have those two results to report. And then when we looked at ethambutol, for ethambutol, most of the children had subtherapeutic concentrations, and this is consistent with what was observed for this particular lower weight band in the SHINE trial. And this table just summarizes the average parameters that were observed. First, with a reference to the pediatric observations in the SHINE trial, and they were on average lower than what we saw in the SHINE trial. And then when we look at the proportion of children who achieved targets, so for isoniazid, only 51% were within the reference target for adults, and for rifampicin, 22% were within the reference range for targets. And for ethambutol, just 6% were in the reference range. So in conclusion, we observed low plasma concentrations for rifampicin, isoniazid, and ethambutol in infants living with HIV who were treated for TB using WHO weight band recommendations, and this was in line with other similar groups of children who've been dosed according to this weight band. We also showed that we had a high proportion of children who had low reference range for rifampicin and isoniazid and ethambutol. And this pattern was observed throughout at day 90 and day 180 for rifampicin and isoniazid. This study has limitations. These were sick infants, so we only got one sample. So we don't have a full PK curve to understand the whole, how the children handled the drugs well. And then, because the usual thing is that sampling of TB drugs is done on an empty stomach, but these were infants, so they couldn't be starved. So we sampled them on a first aid, and we know that after when you sample after feeding, the absorption can delay the point at which the maximum concentration is reached. So there's a possibility that may underrepresent it. And because we're using the assumption that the Cmax occurs at 2 hours, but that's not always the case, especially for infants. For some drugs, it may occur a little bit earlier. For some drugs, it may occur later, and there's a lot of variability in infants as well. But given those limitations, these findings are consistent with what has been observed previously, and therefore supports the consideration for optimizing of dosing of first-line TB drugs for infants. To wind up, to thank the families and the children that we studied in this trial, and the empirical trial groups in Zambia, Mozambique, Zimbabwe, Uganda, and in Spain. And in particular, I want to thank Tom Jacobs, David Berger, and Angela Kowas, who led the PK studies in the Netherlands, and also the Pablo Rojo, who coordinates, who leads this trial from Spain, and my fellow investigators in Zimbabwe, Hilda Mujuru, in Mozambique, Chris Bach, in Malawi, Tisungani Mvalo and Poying, and Victor Msime in Uganda, and Raumo in Ivory Coast. And this trial is funded by EDCTP, and so thanks to EDCTP.
Thank you so much, Dr. Chabala, for this very insightful presentation. We will take questions now. I saw the first and second hand there. Please go ahead. Please go ahead.
Thank you. Hi, this is Martin Murray from Radboud UMC, colleagues of the ones you were mentioning there. And I was just wondering, because you say these first-line drugs needs to be optimized. Now, for isoniazid and ethambutol, that might be a little more tricky because toxicity is maybe higher in the higher doses. However, for rifampicin, it's well known that it's very well tolerated if you optimize the dose quite highly. So did you do any modeling on how high your dosing should be to get these lower bottom bars up above the lower limit of what's normal?
So for this particular, we didn't do that, but I think Paulo is, I saw Paulo somewhere in the audience. They've actually done some modeling on how, using the fixed dose combination, you can try and optimize these weight bands to get the appropriate dosing. And also there are also proposals just to add additional rifampicin to improve this
so
dosing
Paulo,
parameters.
tell me, how high should you go? How high? Is it 70 milligrams per kg?
Your microphone is coming.
Paulo.
60 milligram. Okay.
Okay, thank you. I saw the gentleman at the back has a question. And okay.
Me? Thanks. I'm Stella Eleni, Stella Mpagama from Tanzania. Yeah, so thank you for a nice presentation. What you have seen, of course, as you have mentioned, it is very common. We also found it in one of the studies in Tanzania in children, but one of the things which was correlated was enteropathogens, Giardia infection, noroviruses. Those were the common confounders which led to that. In your study, what are other possibilities which you think they might have contributed your results not to match with the SHINE study, apart from the general description?
Well, I think this with infants with advanced HIV disease, so that could be one of the reasons, because there's some work that suggests that children who have HIV disease have lower drug concentrations, and also nutrition, poor nutrition status was one of the parameters. We didn't look at enteropathogens or the effect of enteropathies.
Okay, please. Yes.
Tom de Croo, Antwerp. Thank you for the presentation. So considering that you have this data and understand you're still enrolling,
Hold on.
do you have any idea about the treatment response and safety profile in those? Could inform any adjustment to the dose while the study is still ongoing, using kind of more adaptive approach to your design?
Yeah, that's a good question. So we first of all, because of the sample size, we were not designed to to link the concentrations directly to the outcomes because of the sample size. And then in terms of dose adjustments, we haven't planned for that within the course of the trial, because I think it requires to do this modeling things to do that adjustment. So we have stuck to what the WHO currently recommends for now. And then because this is an ongoing trial, so we still have yet to review the whole profile in terms of the associated clinical outcomes, because we are still blinded to the data. Yeah.
Okay, we have time for one more, and I see the gentleman had his hand raised. Thank you.
Thank you very much. Just a quick comment on the limitation that you mentioned regarding the collection of one sample for the PK analysis in these children. I was just wondering what the baseline hemoglobin levels were in many. Hear about.
We couldn't hear the last part. Could you please repeat?
Okay, sorry.
Thank you.
We've been involved in the EDCTP trial, EDCTP conducted in children and looking at their PK levels of insulin. And we were able to conduct a number of blood draws in these severely ill children. And we used a minimum value on serum hemoglobin to exclude them from the PK analysis. Were a high proportion of the children enrolled in your study very anemic, and that was why you adopted a single blood draw for the PK analysis?
So because we were using children had the potential to be randomized to receive Valga and Cyclova, and it has is potentially it's got it can cause bone marrow. So one of the requirements before the children were enrolled in the trial was they should have had at least a hemoglobin count above 7. So, and then we also have, I can't remember off the top of my head what the average HB was in these children that we analyzed, but we didn't link this analysis to their hemoglobin count. Yeah.
Thank you, Dr. Chabala. I think we'll move on to speaker number 4 of the day. And that is I'll move on to Professor Friedrich Tinnemann from the University of Cape Town, but also University of Zurich. He's going to talk about spirometry diffusion capacity, absolute lung volumes, and PET-CT findings upon completion of TB treatment, specifically preliminary findings from 2 studies, Statin B and the Extend TB trial. Please go ahead.
Thank you for the introduction. Good morning. Title of my talk is Spirometry, Diffusion Capacity, Absolute Lung Volumes, and PET-CT Findings at the end of TB treatment. This is preliminary findings of the Statin TB trial and now also Extend TB trial. We are a consortium of 6 institutions, Cape Town, Zurich, UNAM in Namibia, where we have the capacity development part of it, Imperial, and then our fantastic management company, Link, and recently we also adopted Gunnar Günther at Inselspital to have a pulmonologist on board. The research was conducted and patients recruited at the University of Cape Town in our research group called General Medicine and Global Health. I just want to highlight that we work at the intersection of infectious diseases and non-communicable disease, and particularly cardiovascular disease and lung disease in the concept of lung TB sequelae. Our research clinic was previously based in Khayelitsha, but we moved due to security reasons more in the center between different townships. So we are now not only recruiting from a single township, but from in total 6 clinics across the Cape Flats. The research group in Cape Town is co-directed by Sandra Mukasa. She's managing the day-to-day activities. Reto Gula, who's also here in the audience, is leading the immunology part at the lab at the IDM. And we actually managed within the Statin TB grant to establish a new clinical trial unit at the University of Cape Town next to the big players of Sattvi Sidri and Desmond Tutu, and have now 250 square meters of lab and clinic space with a lot of functional testing and a large, very diverse team. So the background, as most of you know, but I'm still sometimes puzzled when you're in Cape Town and people ask you how big is the problem of TB. It is a big problem. In Cape Town, it's a particularly big problem. There's still 10 million cases every year with 1.6 million deaths. In the context of HIV in Cape Town, we have an incidence rate of 1.6% in some of the areas. Recurrent cases are about 3 to 5% in Africa, but different modeling showed that actually these cases contribute 10 to 30% of people re-entering the TB control program. It's a big problem. And the study, Statin TB, is based on work that we have done at different PET-CT studies. And I just want to highlight one study which was very important by Fanny Malherbe and Georg Walzel's group, who actually looked at inflammation on PET-CT at the end of TB treatment, and then 6 months and 1 year down the line. And what Fanny actually showed, that we have a large subset of participants who remain with a very high inflammatory response on PET-CT, and some even deteriorating. And in this paper published in Nature Medicine, Fanny actually also found MTB mRNA in the sputum, suggesting that those are actually not sterilized. But we had many discussions around it, and we didn't know, what is this inflammation on PET-CT at the end of TB treatment? What does it mean? Does it mean there is ongoing replication? Does it mean this is a healing response that is needed? And do we need to attenuate it, or is it important to finish off the healing process and repair mechanisms in the lungs? So Reto did work over the last years to actually look at statins and in TB, and he could show in animal models that treating mice with MTB, he actually could reduce the burden of MTB by enhancing autophagy. And he could reduce the lesion size in the mice and also the burden overall. So we discussed how can we put this from the bench to the bedside, and without having too much drug-drug interactions with statins. So we decided we are taking the data that Fanny Malherbe developed and try to attenuate the inflammation at the end of TB treatment. So this is the statin TB trial. It's a very complex trial design and has expanded over the last years. So at 4 months of TB treatment, we take a sputum and make sure that the culture is negative. It's reported 6 weeks later when they finish the TB treatment. We scan them at Cubic, our imaging center, and those ones with persistent inflammation, which we defined as a total lung glycolysis of 50. Those ones were then randomized in the absence of TB treatment. So this is really at the end of TB treatment. We randomize them to 40 milligrams of atorvastatin and identical placebo, and we treat them for 3 months. So these are our methods. We need a CT scanner, then we need this very expensive software MIM, which we use a license from the NIH. And then in order to understand what this inflammation means, we needed to go beyond spirometry. EZ1 Pro is a body box, but it's portable. It's developed by a startup in Zurich, my second home institution. And it actually allows you to measure the diffusion capacity and is therefore a completely new technique that is portable. We are using a standard that is currently updated by the ERS and ATS. One thing that we have noticed when analyzing our data, that we need to include a reference group for our data. And this reference group, the only reference group that is available in the ERS guidelines, is data on Black Americans. So we contacted the chairs of this paper, and they confirmed actually that all the reference values that exist in lung function have not been ever confirmed on the African continent. These are 2 representative scans. There is no inflammation at the end of TB treatment. That does not exist. So we decided that 50 is a cutoff which we considered clinically a lot of inflammation. This is a representative scan on the right-hand side with a lot of inflammation. Our recruitment progress is that we have by now recruited 170 participants, and in those ones we have already 10 recurrent cases. But I can only show you the data of the 106 participants that we submitted at the time when we did submit the abstract. So it's a young population of 30 plus years, 30% are female. Previous TB is a problem in our setting with about 30% of our participants, 22% are HIV infected. And we have a large number of smokers, but if you dig into it a little bit, you can see that they actually only smoke 1 to 2 cigarettes per week, so very low pack years. We have 80% of participants who consider themselves asymptomatic, and the most common symptoms at the end of TB in 13% of cases is cough and dyspnea in about 9% of cases. And then the results from the CT scan and PET-CT showed that we had total lung glycolysis above 50, so severe inflammation in 50% of cases. And these are the results of the lung volumes. This is really automated according to the ERS guidelines. And this takes the diffusion capacity into account. So this is very novel. This is not spirometry only. And the interesting finding is that we actually have a group of about 1/4 of participants who have hyperinflation. So this is a purely obstructive pattern. So those patients actually can be treated with bronchodilators. 30% have normal lungs, yes, and they have normal lungs also on the PET-CT scan, or fairly normal. And then there is a large group of 40% that have a restriction, and I think those ones are particularly important, as there's nothing that we can offer to those patients. Now, if you look at the diffusion capacity, so this is the oxygen that goes into your bronchial system and actually enters into your bloodstream. 60% had no impairment in terms of the DLCO measurement, 20% mild, and 22% had moderate to severe impairment. So they receive less oxygen, and you have a lot of cardiovascular comorbidities that can be created or that develop through this. One of them is pulmonary hypertension. Now, when we want to look in more detail what these pulmonary function tests mean in terms of inflammation in the lungs, we had our two strata, those ones with very little inflammation and those ones with a lot of inflammation on the PET-CT scan. And we're using the Z-score so that we can compare different age groups and sexes, but again, based on data on African Americans. We use the Z-score to look at differences between those ones without persistent inflammation in the lungs and those ones with high inflammation. And if you look at the FEV1 and the full vital capacity, there was a significant difference. But if you look at the Tiffinau test, that did not reach significance. But what is interesting, and these are the two lines at the bottom, is the DLCO, and those ones without inflammation in the lungs, they actually had 90% of predicted, whereas those ones with inflammation in the lungs have only 70% of gas exchange compared to the predicted mean. And that is now the first time an answer. What does this inflammation mean? It means that less oxygen arrives at the organs. And then we plotted that and looked at the correlation, and there is a clear correlation between total lung glycolysis. So the more inflamed your lungs are, the worse is your score. And that is particularly relevant for those ones who are HIV uninfected. Those with a HIV positive, which is the blue or purplish color, the correlation is much less. And we haven't analyzed the data according to HIV status yet, but our hypothesis is that those ones who are HIV infected have less immune response and actually less damage to the lungs. And I think many of you would agree that this is the case when you think of the chest X-rays of people who present with TB-associated HIV or HIV-associated TB. So the take-home message is that EDCTP is actually a fantastic capacity development program. There's a new research unit at the University of Cape Town, and an excellent career builder to many people in the room who are part of GMGH. And we actually also contributed significantly to the transformation policy at UCT. We have a very diverse team. It's female-led on the ground, and all colors are present. The take-home message that in our very young adults at the end of TB treatment, we have very commonly persistent inflammation based on PET-CT, and those ones are at a high risk of having recurrent TB, 6% recurrent rate, which is about what we expected, and 90% of those have inflammation in the lungs. So from a recurrent point of view, inflammation in the lungs is bad. And then only 30% actually have normal lung functions, 60% have normal gas exchange, but we have 1/4 with moderate to severe impairment. And then we have an association between DLCO and persistent lung inflammation. And the team that was part in analyzing the first 106 are listed below. Karen Volmerans is leading the PET-CT and the lung function analysis in my group. I want to thank everyone. Maybe just very briefly, because we are applying for a no-cost extension in about 2 hours. We got endorsed by the WHO. Here's an official letter. This is a very important study, and we really need to finish it. We are behind time because of COVID-19. Thank you so much. To post this.
Thanks a lot. Very interesting and also lovely take-home message at the end.
The no-cost extension.
Oh, the first one. But both are welcome. Maybe I'll just, without delaying, I'll take 2 or 3 questions from the audience. Do I see a hand? Yeah. Go ahead.
Hi, I really enjoyed your presentation. I just wanted to find out, as a follow-up to these cases that you're finding with recurrent TB and what are you going to do for these patients in terms of pulmonary rehabilitation and other solutions past the project that you're doing?
Yeah, so thanks. Very important. And so what we saw, the statin TB is a proof of concept, very short trial, 3 months, and then another 3 months of follow-up. And we had many discussions while we were recruiting. We really need to keep them in our study. So we applied for an NIH grant, and the study is called Extend TB. So it's statin TB and now Extend TB, and now we have a follow-up of 2 years in total. But your question about pulmonary rehabilitation and those ones who are reading the literature, there is very little, but there are studies coming out also from India. Pulmonary rehabilitation makes a big difference in terms of lung outcome. It has never been part of our primary healthcare system. Unfortunately, it takes up a lot of resources, a lot of physiotherapists. But we are looking into this and want to actually develop a trial setup to look at the effects of pulmonary rehabilitation in our context in Cape Town, our TB cases, and with very, very sophisticated investigations as endpoints.
Thank you, Jean-Marie. Nice message, the second one. I agree. Just a question from physiology-wise. I'm also a respiratory physician, and I loved your presentation. I think it's very valuable. However, I think your conclusion that severe and moderate impairment of DLCO leads to less oxygen in the tissue is not always true. There's a lot of compensation mechanism. It can lead to comorbidities. I agree with that. But it doesn't lead to hypoxemia as a principle, always. What's your comment?
Yeah, did you mention that I was an infectious diseases physician?
Yes, I did. No, I didn't.
That is my disclaimer.
Sorry for that.
And we adopted Bern so that we have Gunnar, pulmonologist, on board. Thank you for your question. Thanks. Acknowledged. Can discuss later.
Frank Obelins, University of Amsterdam. Thanks very much for the presentation. Really wonderful. You found these striking associations with recurrent tuberculosis. Have you been able to look at whether that is reinfection or relapse? Because there has been this data, epi data from Cape Town from more than 10 years ago, suggesting that if you have had tuberculosis, you actually have an increased risk of reinfection, although that has never been reproduced anywhere else. Have you been able to look at that?
Yeah. So I mean, this is data that was I think from Desmond Tutu Foundation that in the first year post TB, your highest risk of getting TB again, is in this very short time frame. This is a proof of concept really to look at the effect of atorvastatin. So we couldn't manage to actually start recruiting them at the beginning of TB treatment and harvest the culture and so the answer is no. So we call it occurrence and not relapse, and we are aware of this shortfall.
Another question? Maybe one from me before we get another hand. On the strategy level, EDCTP3 has non-communicable diseases in its scope. Based on the studies you've been doing, but also knowing that you are infectious, but also cardiovascular physician, or you do infectious cardiovascular disease research, is there one take-home message for us to look at what we should include in our core topics to take up these questions which are I see them as neglected by infectious diseases funders, and ourselves we do have that in the scope in our strategy, but not yet a specific topic. So is there any small take-home message that I can use for our core topics drafts actually?
There is. I just actually, can you just go back to the presentation? So we have two trial designs. We have the statin TB trial that ends, do I have a mouse here? That ends here. And then in Extend TB. So when we saw our participants, we had quite a large group who were short of breath, and we were thinking, is this all pulmonary or is there a cardiovascular component? So EDCTP is written that we embedded CMRs into the study, and you can see that at the end of TB treatment we're doing a cardiac MRI, and then repeat that at 12 months. So have another secondary endpoint in terms of the effects of statin. It's a cardiovascular drug as well, and then we repeat that at 1 year and another CMR at 2 years. So all of this is funded through the South African MRC and an NIH grant. We did present this at the ESC last year, the very baseline data that we see myocardial impairment in about 30% of cases. But again, we do not have a control group here. We do not know. There is a control group that we're currently developing and scanning 1,000 healthy people in the Cape Town metropole, but we haven't analyzed the data. But cardiovascular component in the long-term sequela is important, and excess mortality after infectious diseases needs to be looked at. The EDCTP grants are always too short. We talk about 25 years here.
Taken. Thanks a lot. Thanks a lot. And I'll hand over to my colleague Alex to invite the next speaker. Thank you.
Thank you so much, Dr. Sienemann. So the last two speakers for this session will take us into discussions on HIV, starting with HIV therapies. We have joining us Ontlametse Bareng, speaking about treatment outcomes of low-level viremia among adults living with HIV on dolutegravir-based first-line antiretroviral therapy in Botswana. And Ontlametse Bareng is a PhD student based at Botswana Harvard Health Partnership, who is registered with University of Botswana. She's currently working on evaluating the clinical impact of low-level viremia among people living with HIV on ART in Botswana, and the work is funded by TESA Network and Fogarty NIH. So please, the floor is yours.
Thank you for that introduction. I'm Ontlametse Bareng, a PhD fellow based at Botswana Harvard Health Partnership, who is also registered with University of Botswana. I'll take you through my presentation titled Treatment Outcomes of Low-Level Viremia Among Adults Living with HIV on dolutegravir-based first-line antiretroviral therapy in Botswana. People respond differently to the use of ART. The main objective for the use of ART is to sustain virologic suppression. However, there are some individuals who fail to suppress but experience what is called virologic failure. Despite individuals experiencing viral suppression or virologic failure, there is still a subset of individuals who experience what is known as low-level viremia. Currently, low-level viremia is defined differently depending on the HIV treatment guidelines used. And we have WHO with the highest range for definition of low-level viremia from 50 to 1,000 copies per ml. So this lack of standard definition for low-level viremia have led to conflicting data on the association of low-level viremia when it comes to virologic failure. Therefore, the study here intends to determine impact of low-level viremia among individuals living with HIV who are currently enrolled on dolutegravir-based first-line antiretroviral therapy from June 2016, when Botswana started using DTG, to December 2022. So with the specific objective of determining the trends of low-level viremia over a period of 5 years, and also to determine if low-level viremia was associated with virologic failure. In order to answer these questions, a retrospective longitudinal analysis was done using data set from people living with HIV who are aged 18 years and above, and these individuals were enrolled on Botswana HIV National Program. These individuals should be initiated on DTG from June 2016 to December 2022, and they should have on ART for at least 3 months and have viral load measurement available. From the viral load measurements that were extracted from individuals who met the study inclusion criteria, this viral load were characterized into 3 viral load groups, starting with viral suppression, which was defined as viral load less or equals to 50 copies per ml, virologic failure for viral load above 1,000 copies per ml, and lastly, low-level viremia for individuals with viral load between 50 to 1,000 copies per ml. Low-level viremia was further classified into 3 groups, which was low LLV, medium LLV, and high LLV for viral loads from 50 to 200, 200 to 400, and lastly 400 to 1,000 copies per ml respectively. Furthermore, low-level viremia was classified into how many times it occurred. So it started with a single instance of low-level viremia, secondly confirmed low-level viremia. These were 2 consecutive LLV measurements, and lastly persisting low-level viremia, which was at least 3 consecutive LLV measurements. The prevalence of viral load groups were stratified into the duration of time on ART, starting at 3 to 6 months category, and the last duration was greater than 60 months. So individuals with multiple viral load measurements falling within a single duration were classified into the viral load group of the highest viral load measurement they achieved. And also to determine association of low-level viremia with virologic failure, this analysis included individuals with at least 2 viral load measurements, and they should have not experienced virologic failure at the first viral load measurement. So in this study, the exposure was defined as the first and subsequent low-level viremia measurement after initiating DTG. And the outcome was experiencing virologic failure when individuals have initial viral load below 1,000 copies per ml. So in order to identify factors associated with virologic failure, Cox proportional hazard models was utilized. Now moving on to the study results. So here the viral load groups were stratified into the duration on ART. So it started at 3 to 6 months category, and lastly we have greater than 60 months. So among individuals with viral load measurements, we reported that the virologic suppression, the lowest was 94.5%, while the highest that was reported was 95.7%. Now, when we zoom into individuals with low-level viremia, we found that the lowest low-level viremia prevalence reported was 2.6%, with the highest of 3.9%. So now I would like to zoom into individuals with low-level viremia, and it shows that most of individuals with low-level viremia were experiencing low LLV, which is viral load from 50 to 200 copies per ml. So in general, if we look at individuals with viral load above 50 copies per ml, we can see that approximately most of them were not suppressed with viral load falling between 50 and 1,000 copies per ml. So this shows that low-level viremia is occurring frequently among people who are not suppressed. Now moving on to determine if low-level viremia was associated with virologic failure. In this first analysis, low-level viremia was grouped as one group. And in this Kaplan-Meier curve here shows that individuals with low-level viremia takes short time to present virologic failure when compared to individuals with viral load below 50 copies per ml. Now looking at the hazard ratio multivariate analysis where it shows that we adjusted for other variables, there was 2.0 hazard of presenting virologic failure when compared to individuals who were virally suppressed. Now in the next analysis, low-level viremia was stratified into 3 LLV ranges: low LLV, medium LLV, and high LLV. So the Kaplan-Meier curve here also shows that individuals with high LLV takes short time to virologic failure when compared to other LLV ranges. But when we compare this 3 LLV ranges, we can see that individuals with them takes short time to virologic failure when compared to the virally suppressed individuals. Now moving on to the hazard ratios. Low LLV had 2.1 hazard ratio to virologic failure, medium LLV 2.9, and high LLV 3.3. So this shows that individuals with low-level viremia were associated with increased hazard of presenting virologic failure. So an increase in LLV range was associated with an increase in the hazard ratio of presenting virologic failure when compared to virally suppressed individuals. Now, when the low-level viremia was stratified, how many times it happened. So the first one was single LLV, confirmed LLV, and persisting LLV. So I have already explained what they mean in the previous slides. So individuals with persistent LLV took short time to present virologic failure when compared to individuals with confirmed LLV and single LLV. However, all these LLV occurrences took short time to present virologic failure compared to the virally suppressed individuals. And the hazard ratio of presenting virologic failure when an individual have a single LLV was 2.1, 2.4, confirmed LLV it was 3.1, and lastly persisting LLV was 6.6. So this shows that an increase in the LLV episode was associated with an increase in the hazard ratio of presenting virologic failure when compared to virally suppressed individuals. In conclusion, low-level viremia continues to be an early warning indicator for virologic failure, even on the highly effective DTG-based first-line antiretroviral therapy. Therefore, the study here recommends lowering virologic threshold to viral load greater or equals to 50 copies per ml. And this virologic failure threshold should be used as an indicator for frequent viral load monitoring, which should be accompanied with intensified adherence support. And also the study recommends HIV drug resistance testing among individuals with persisting low-level viremia, which will help with the selection of appropriate ART. Also, our study findings had impact on the management of individuals with low-level viremia in Botswana. Previously, Botswana used to define virologic failure as viral load above 400 copies per ml after 6 months on ART. And recently, the country have released new guidelines where virologic failure threshold have been lowered to confirmatory viral load above 200 copies per ml after 6 months. So this is how the country is now going to manage individuals with confirmatory viral load above 200 copies per ml. These individuals will be initiated on dose monitoring weekly for 30 days, and after 30 days, these individuals will go through viral load testing. Individuals who have persisting viral load above 200 copies per ml will be then tested for HIV drug resistance mutations, and then from there, they will be given ART depending on their HIV drug resistance profile. However, this guidelines still have some limitations as it is leaving out individuals with viral load from 50 to 200 copies per ml, as we have seen from the study that these individuals are also at risk of presenting virologic failure in future. Lastly, I would like to acknowledge Botswana Harvard Health Partnership for giving me the opportunity to do this PhD work. And I would also like to express my gratitude towards my supervisors, Dr. Simane Khaisitsi, Professor Sikhulile Moyo, Professor Motswaledi, Dr. Irene Gobe, and also my mentor from TESA Network, Dr. Rosemary Musonda. I would also like to acknowledge the funders of this work, TESA Network and NIH, Fogati. And lastly, I will express my gratitude towards our collaborators, Ministry of Health, Botswana, and also BOOM. And also acknowledge EDCTP for travel scholarship for me to come here and present this work. That's all I have for you.
Thank you very much, Otlamense. Very interesting presentation and very meaningful results. So thank you for that. We will now be opening the floor for questions. So please do raise your hand if you have any questions. And just to remind those online that we are still monitoring our questions on the app. So please feel free to post them there. Any hands? Yeah, here and then at the back, the next one, please.
Thank you very much for a lovely presentation. I was just wondering about because the tests have become a bit more sensitive. Can you still hear me? Yeah, good.
Yes, now we can.
Tests have become a bit more sensitive over time, and that's one of the reasons why people have sometimes said a 200 cutoff is okay. I mean, they recommended that for clinical trials for a while, etc. So, do you have any comment about that? And also, you were suggesting that you do resistance testing if it goes above 200, but the rate of failure of resistance tests, if you've got quite low levels, that in other words less than 1,000, is quite high. So I wonder whether you comment on that as well. Thank you very much.
Thank you for the interesting comment. Yes, we acknowledge that when you go down below 1,000 copies per ml, the genotyping success is also going down. But because of the availability of in-house genotyping assay, frequently from our lab, we have managed to optimize an in-house genotyping assay for samples below 1,000, and also the use of proviral DNA sequencing can be utilized when the samples are failing with plasma. And also there are more sensitive genotyping assays such as next generation sequencing that can be utilized during viral loads below 1,000 copies per ml.
Thank you. That was the question at the back.
Thank you so much for the communication. This is Joseph Fokam from Cameroon. We are doing a similar studies also in our context. My question will really be to look at the what can we take back home as evidence-based recommendation, because if patients are failing on dolutegravir, we know dolutegravir has a very high genetic barrier. It is also highly potent, so developing resistance is not that common as other drugs. However, we have been seeing some cases of failure with resistance, even for those who have low-level viremia. So what's your preliminary experience among these patients with viremia? Are you seeing some with drug resistance mutation already? I think that will really give stronger evidence for the WHO to take actions. Thank you. Thank you for that comment. On the next steps for this work, we are intending to genotype individuals with low-level viremia on DTG, but previously we have genotyped individuals with low-level viremia who were on NNRTI, and from the analysis we have found that individuals with low-level viremia harbor the same prevalence of drug resistance mutations as individuals who are failing with viral load above 1,000 copies per ml. So this is very evident that some of individuals with low-level viremia will harbor HIV drug resistance mutations.
Thank you. Yeah, I see one here, and then the next one there, please.
So a colleague of us, Tom de Croo, Antwerp, a colleague of us is studying the same topic and is really interested in distinguishing non-adherence from failure based on viral loads. So in the absence of resistance testing, do you have any idea on how to approach this question? The difference between how to distinguish non-adherence from increasing viral loads or being low viremic or high viremic?
Thank you for that interesting question. So from the Botswana new HIV treatment guidelines, before they can do HIV drug resistance mutations testing, they would want to ensure that these individuals are not suppressed due to lack of adherence support. That's why they are going to implement dose monitoring weekly for 30 days, whereby a patient will come to the clinic on a certain day to check if they are taking their medication well. So from there, that's when they are going to check if these individuals are failing due to HIV drug resistance mutations.
Great, yeah, please.
I'm Yasu from Addis Ababa University, Ethiopia.
My question is, you have recommended that resistant testing might be good when someone comes up with low-level viremia. My fear is, and my concern is, in African setting, where this testing may not be available, even if available, might be expensive. How feasible do you think this would be? Thank you. Thank you for that question. Yes, we acknowledge that some of the African settings have limited resources to test HIV drug resistance. However, there are cost-effective assays that we have seen them from the publications, and also even NGS is not a very expensive test. I assume that most of the labs in African settings should be able to do HIV drug resistance testing, or in situation where the labs don't have resources, they can opt to send to other laboratory settings to help with HIV drug resistance testing.
Yeah, thank you, Dr. Abida. Dr. Ontlamete. Dr. Abida is the next speaker. Thanks a lot. I think the questions... The questions which are being raised, especially one from FOCAM, will be answered by the next speaker, maybe partial or totally. Now I would like to invite Dr. Bida Khan, who is working at the Department of Virology in KwaZulu-Natal. She'll be talking about high levels of HIV drug resistance that persist in ART-experienced patients post-dolutegravir rollout in KwaZulu-Natal specifically. Thank you.
Thank you for the introduction. Good day and bonjour to the lovely audience, and thank you for staying till the end of this session. And today I'm going to present our work being done in KwaZulu-Natal, South Africa, on monitoring HIV drug resistance during our transition to dolutegravir-based antiretroviral therapy. And I would like to thank EDCTP for this amazing opportunity. And I'm going to present this work on behalf of Dr. Benjamin Chimukangara, who is an EDCTP fellow and the supervisor of this project, and Dr. Lelisha Gaunda, whose PhD work this is. So this is the outline of the presentation. I will begin with the research problem and research objectives, and then move on to the methods, results, and end with key messages and acknowledgements. So the research problem that we identified is that HIV drug resistance remains a major threat to achieving sustainable viral suppression on antiretroviral therapy, and that there is no real-time monitoring of HIV drug resistance levels in KwaZulu-Natal, South Africa. To address this research problem, we set out these research objectives, which were first to create a near real-time database with a linked dashboard for identifying HIV drug resistance hotspots in KwaZulu-Natal, South Africa, and then to characterize the drug class mutation patterns among patients failing antiretroviral therapy, including those on integrase inhibitor-based ART regimens, and then to use this database knowledge to advise on the use of health resources for HIV prevention and treatment services. To do that, we obtained HIV drug resistance data from the National Health Laboratory Service Central Data Warehouse for the period January 2018 to June 2022. In South Africa, we transitioned to dolutegravir-based antiretroviral therapy for both first-line and second-line antiretroviral therapy towards the end in December 2019. The transition to dolutegravir, however, has been a bit slow initially, especially with challenges faced during COVID-19 pandemic. So you will see that the numbers on DTG are much lower. And then we used Power BI, which is a Microsoft-based tool, to create the database with the linked dashboard. and this was analyzed and stored at the discipline of virology based at the University of KwaZulu-Natal. This slide puts our methods into context. You will see a map of Africa which shows HIV prevalence among adults aged 15 to 49 years. And as I'm sure the audience is familiar, we have high HIV prevalence in sub-Saharan Africa. South Africa, which is at the southernmost tip of Africa, has the highest HIV prevalence globally. And in 2022, South Africa alone had approximately 160,000 new infections, which equates to 1 in 8 persons infected globally being South African. And then taking a closer look at the map of South Africa, you see that there are 9 provinces in South Africa. KwaZulu-Natal is on the east coast and has the highest HIV prevalence amongst all the provinces in South Africa of 24.9%. And this is where we curated our HIV drug resistance data. Moving on to our results, this table shows the baseline demographic and clinical characteristics of the median age was 35, or we divided it into a pre-DTG rollout period between 2018 to 2019 and a post-DTG rollout of 2020 to 2022. The majority were female, and also the majority were on a boosted lopinavir, which is a protease inhibitor-based regimen. And during 2020 to 2022, which is the post-dolutegravir rollout, there were some number of individuals on dolutegravir-based ART, as indicated. And as these results are expected because HIV drug resistance testing in our setting, as per the national guidelines, is indicated for patients with confirmed virological failure, which is a viral load of 1,000 copies per ml and above, on a protease inhibitor-based or an integrase inhibitor-based ART regimen. So out of more than 4,000 genotypes curated, we had 6 out of 7 that had HIV drug resistance mutations present. We noticed that the proportion of HIV drug resistance mutations were higher among adult females 15 years of age and above. 1/3 of the genotypes had multi-class resistance with 3 or more drug class resistance mutations, which were mainly nucleoside reverse transcriptase inhibitor and non-nucleoside reverse transcriptase inhibitor mutations. We found that only 50 genotypes had integrase resistance data, from which 9 out of these 50 had intermediate to high levels of resistance to dolutegravir. So this, looking at the trends of HIV drug resistance classified by the drug class. On the x-axis, you will see each year of the study, and the y-axis is the proportion of HIV drug resistance mutations that were present. And what we see is that there were high levels of nucleoside reverse transcriptase inhibitor resistance, the blue bars, as well as high levels of non-nucleoside reverse transcriptase inhibitor resistance, the yellow bars, during the entire period of the study, including pre- and post-DTG rollout. We also found a decline in protease inhibitor resistance, the green bars, following DTG rollout. And then post-DTG rollout, we also found a few cases of integrase inhibitor resistance. Looking more into detail, this figure describes the most common HIV drug class resistance mutations classified by the drug class. And the most common drug resistance mutation, as expected, that we found was M184VI, which is the signature lamivudine emtricitabine mutation, followed by the signature efavirenz in an RTI resistance mutation K103NS, followed by several protease inhibitor resistance mutations. And then on this side, of those that had integrase inhibitor resistance, you can see these were the most common resistance mutations that we found, including E138K80, which is a common polymorphic accessory mutations, and then G118R and R263K are common integrase inhibitor resistance mutations in integrase inhibitor naive patients who develop DTG resistance. And now the last part of the results looks at the hotspot mapping. And this map of KwaZulu-Natal shows the district classification. There are 11 districts in KwaZulu-Natal. Each circle on the map represents a healthcare facility, and the color of the circle represents the proportion of HIV drug resistance that was found in that facility, and it ranges from 0 to 25% in blue up to 75 to 100% in red. And then the smaller map gives you the district classification, where the pink is rural, yellow is peri-urban, and blue is urban. So overall, the HIV drug resistance prevalence was high among all the districts, and it varied from 76 to 96%. As you can see, the majority are red dots or circles. The hotspots were localized to peri-urban districts, and we also noticed that despite rural districts having fewer HIV drug resistance genotype requests, if you look example at northern KwaZulu-Natal, like Zululand district and Umkanyekude, they had fewer requests, but the HIV drug resistance prevalence was still higher compared to peri-urban and urban districts. So with that, our take-home messages that we would like to impart is that even though it's still early days, HIV drug resistance levels remain high in KwaZulu-Natal, South Africa, despite transition to dolutegravir-based antiretroviral therapy. So we still need to continue monitoring this, so watch the space. We noticed that a subpopulation of individuals may not fully benefit from dolutegravir use due to multi-class drug resistance, at which point protease inhibitor-based antiretroviral therapy is warranted, such as a boosted darunavir. And this is supported by the data that we found that there was a decline in protease inhibitor resistance post-DTG rollout. Also, the need to strengthen HIV treatment services, especially in peri-urban and rural healthcare facilities in KwaZulu-Natal, with adult females needing priority care. And that near real-time monitoring of HIV drug resistance is important to ensure sustainable dolutegravir use in first-line and subsequent antiretroviral therapy regimens. And with that, I would like to thank EDCTP for funding to make this work possible, as well as support from the University of KwaZulu-Natal, National Health Laboratory Service, CAPRISA, and the Department of Health, South Africa. Thank you for your attention.
Thanks a lot, Dr. Khan. I'd promised in the beginning that we'll have a general Q&A, but I probably won't have that. But we do have 5 minutes or 4 where we can ask 2 or 3 or 4 questions to Dr. Khan. First hand, behind there.
Thank you. Fantastic work. My name is Sikulile from Botswana. I'm interested in the subset of patients with INSTI mutations. You said they were treatment naive. What was the background, and where was the background okay? Did they fail the background and then had INSTI, or they just had INSTI alone? Just were those from a multi-class? It would be interesting because 12%, 8% would definitely be very, very high.
So most of our population in KwaZulu-Natal is antiretroviral therapy treatment experienced individuals. And for HIV drug resistance testing, usually as part of our national guidelines, most of our patients that we do drug resistance testing are on second line ART, and they're failing second line, so they have previously failed an NNRTI-based regimen. So, and we also have pre-existing high levels of NNRTI transmitted drug resistance. So already there's NNRTI resistance. Also a large subset have NRTI resistance as well. And also a lot of those who are on integrase inhibitor-based regimens that have transitioned. Some of them have also been on a previous protease inhibitor-based regimen, such as boosted lopinavir. So a subset do have PI resistance mutations as well. So most of our patients who we found that developed DTG resistance, they've had a compromised NRTI backbone. And there's been very few cases where they have been ART naive and developed DTG resistance.
Second question there.
Okay, thank you. Just a very quick one. I was very interested in seeing the decreasing rate of resistance to PI drugs. Could it simply not be the fact that as we transition to dolutegravir, we reduce the number of patients who are on PI-based regimen? Then just two quick comments also. I think this is a clear data showing why we need to have drug resistance testing in Africa, even if we believe dolutegravir seems to be very potent. So what can we really recommend in terms of point-of-care HIV drug resistance testing for the African countries also? And the other issue also will be how can we leverage on point-of-care adherence tests as well? Because we have seen about 70% of those patients had resistance with N184V, which means the other people were surely non-adherent to treatment. Yes, so what do we do to support non-adherence so that we can really detect those who are really in need for drug resistance testing also in Africa? Thank you.
Yes, many thanks for your interesting comments and questions, and I fully support your comments. With regards to the decline in protease inhibitor resistance following dolutegravir rollout, so I agree that it's a possibility that as more patients are transitioned to dolutegravir and there's less exposure on protease inhibitor, particularly boosted lopinavir-based regimens, that there should be a decline in protease inhibitor resistance. Although at the lab currently, most of our current requests for HIV drug resistance genotypes are still primarily patients failing boosted lopinavir-based regimens, but we do anticipate that in the coming years, most of our requests will be due to failing integrase inhibitor-based regimens. With regards to the point-of-care testing, I know there have been several publications looking at assays where you look at PCR targeting the most common mutations. So perhaps we could, so as I mentioned, we're seeing mostly certain mutations, so you could have assays that look for those mutations. And there are also other type of assays being developed for that are more cost effective and near point of care, because I do acknowledge that HIV drug resistance testing is not easily accessible, and you do need experienced staff and a fully functional lab to do HIV drug resistance testing. Also, with regards to point of care adherence, there's also a lot of studies looking at measuring drug levels such as urine tenofovir levels, or even looking at DTG levels in blood. So these could be used as a proxy for adherence. And if these levels are low, then it could be sort of a gatekeeping whether drug resistance testing is indicated, because currently the cost of HIV drug resistance testing is quite prohibitive in South Africa. It's quite an expensive test, and we do gatekeeping of the results. So there is definitely a need for more cost-effective solutions, and also point of care or near point of care solutions as well.
Thank you. One more last question, very quick and very quick answer.
Okay, thank you.
Sorry.
Yeah. Yasu from Addis Ababa University, Ethiopia. I don't know, was it start? Okay. Okay. Shortly after its introduction, resistance emerged to glutugrabir. And that is very alarming, you know. No doubt that the resistance will be even. I wonder what the causes of this resistance emergence is, if you have come across. Furthermore, have you observed any cross-resistance with other drugs as well? Thank you.
Quick answer, please.
Yes, thank you for the question. Yes, it is very concerning. But I have to note that our population in KwaZulu-Natal, we have the largest antiretroviral therapy program. And as I mentioned, most of the patients are treatment experienced. So there's already a background multi-class resistance, which could contribute. Our population also has other issues with adherence, socioeconomic issues, and these all contribute to suboptimal adherence, including like co-infections like TB. A lot of patients present with advanced HIV disease, and these all contribute to suboptimal adherence, and then this is a factor that contributes to drug resistance. And even though dolutegravir has a high genetic barrier to resistance, it's still not immune to getting resistance. So we are still going to get cases of resistance emerging, as we've seen.
Thanks a lot. This is my moment to thank all the participants who are sitting in this room, the speakers, my co-chair Alex. And then encourage everyone to follow up with the questions off and online. There's one question which came online that is for Friedrich. You can look at it and answer in the app. But the rest, I wish you the next second half of the day. Alex, over to you.
Thank you, Jean-Marie, and thank you to you as well for co-chairing. And before we close, just to let you know, just to highlight the next sessions of the forum program. Coming up, we have a networking lunch, yay, followed by poster presentations and a workshop on Horizon Europe, as well as parallel sessions this afternoon. So again, thank you so much to all speakers, and enjoy the rest of your day.